Hi guys, can you hear me? Great, lovely. My name is Ashka. I'm one of the doctors working at Liverpool, at the Royal Liverpool Hospital. Um, Today I'll be doing a session about general surgery. I don't expect the turnout to be great today, given the lovely weather outside. So well done for those of you who showed up. Um, Yeah, so we'll just make a start and hopefully not keep you here for a long time. If you've got any questions while we're going through the questions, put them in the chat and Holly will answer them. I don't know if most of you have been to one of our sessions before, but the way that it works is we go through 15 questions first and it's timed. So I give you a minute or sometimes less to work out the question, and then we go through all the answers at the end. So let's make a start. All right, this is the first question. Okay, next question. All right, next question. Okay, next question. Okay, next question. 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 That's it. Well done. Um, so we'll go through the explanations next in a moment. We'll also put up some polls for each of the questions if you guys could put your answers in, and then we'll go through the explanations. Any questions, put in the Q&A or in the chat and Holly will answer them. Okay. So just launch the first poll. Okay. Great. So this question is about a patient who's got right upper quadrant pain, and on examination they have a fever, positive Murphy's sign, they've got raised infection markers but normal LFTs. What do you guys think is going on? If you can put it in the chat, please. Great. Yes, it is cholecystitis. Most of you guys got the correct answer, which is E. E. coli. So let's go through the explanation. So gallstone disease, it's a very common presentation in general surgery. Risk factors, as you know, include the 4S, so female, obesity is a factor, being a person who's above 40 is more at risk, and someone who's pregnant is also more at risk of gallstones. So there's three presentations that you need to know about. So there's biliary colic. What happens in biliary colic is you've got a stone which is impacted at the neck of the gallbladder, or it's in the cystic duct. And what happens is after heavy or fatty meals, your gallbladder wants to contract to be able to expel, the bile into the duodenum to aid digestion. When it does that, it's going to contract against the stone, and this is going to cause pain. So this is what causes the biliary colic. Acute cholecystitis is when you have inflammation or infection of the gallbladder itself. So it can be calculus, which is the most common cause, where you've got again a gallstone impacted at the neck or the cystic duct, and this causes stasis of the bile, and this provides like the perfect environment for bacteria to grow and proliferate and cause inflammation or infection. You've also got acalculous cholecystitis, and this is less well understood. It's a condition where you don't really have stones, but it's due to severe illness, and the patient is usually septic, hypovolemic, and this can cause inflammation of the gallbladder as well. It has a poorer prognosis compared to a calculus acute cholecystitis. And then you've got ascending cholangitis, and this is infection of the biliary tree. And this occurs because there's an obstruction in the CBD, in the common bile duct. That can be a stone. It can also be strictures or malignancy, causing an obstruction there, and this causes bile stasis. Again, and this provides the perfect environment for bacterial growth and proliferation. Next, so this is acute cholecystitis, just the presentation. They present with right upper quadrant pain and fever, as in the question. Murphy's sign is positive. Investigations include bloods, so full blood count, LFTs, user needs CRP, coagulation screen in case they need surgery, imaging. The abdominal ultrasound is usually first line. So normally on the abdominal ultrasound, if you see a dilated CBD, then you would consider doing an MRCP for this patient in case they might have had a CBD stone that's passed or not yet passed. So management is usually IV fluids to rehydrate them if they're septic, or for resuscitation, IV antibiotics to treat the infection, analgesia, usually laparoscopy. The definitive management is a lap cholecystectomy, and this is done within 1 week of diagnosis. But normally in hospitals, you will find that it's pretty much done within 72 hours of patients being presenting to the surgical assessment unit. So this is associated with improved outcomes, shorter hospital stay, and fewer complications compared to previously when a delayed cholecystectomy was advocated. If a patient is septic or very unwell, has a perforated gallbladder or collection around that site, then usually what is done is a percutaneous cholecystostomy tube, and this tube will drain anything that's there, and then this is followed later on after 2 to 3 months by an elective cholecystectomy. Great, so next question, if we can have the poll, please. Lovely. Okay, we'll end it here. It's quite split for this one, so I'm going to take the time and go through each of the answers. So we have a 37-year-old man. We've had an elective cholecystectomy. The procedure was technically difficult. A drain was inserted. 48 hours later, the nurse calls the doctor who's on call to review the patient as they are in worsening abdominal pain. On examination, they are tachycardic, they've got a temperature, and the drain content appears to be bilious. So here, the most likely, what is the most likely post-surgical complication? And the answer is D, a bile leak. So let's go through this in detail. So let's go for why the other answers are wrong first. So in this question, gallstone ileus occurs gallstone ileus would occur if there's a fistula between the gallbladder and the duodenum, which allows passage of a gallstone to the small bowel, and this leads to an obstruction. So that's gallstone ileus. And here, this patient isn't presenting with signs of obstruction anywhere. Bleeding, there's no blood in the drain, it doesn't talk about any sure, they're tachycardic, but we're not talking about hemodynamic instability or anything like that. The HB is not mentioned. post-cholecystectomy syndrome, this can occur after cholecystectomy if there's usually the most common cause is if there's a remaining like gallstone in the CBD and it's still causing symptoms. So there's still a remaining stone that's in the biliary tree that's been missed or that hasn't been taken out, and this will continue causing symptoms, and it will cause deranged LFTs, and it will cause patients to have the typical kind of biliary colic symptoms after they've had the operation. A bile leak is something that can be common after a cholecystectomy. So if you think about how the operation is done, essentially they remove the gallbladder and they cut here at the cystic duct, and then they close this stump here. Now, if this hasn't been closed properly, now in this question it says that this procedure was technically difficult and they left a drain in and all of that, and the drain output, it appears to be bilious. And if this hasn't been sutured properly or closed properly, stapled, so that there might be a bile leak, and this would be present in the drain. What can also cause a bile leak is if there was a common bile duct injury, for example, during the operation. Again, it said it was difficult technically, so there might have been an injury, and this can also lead to a bile leak. So we don't know which scenario it is, but in this question, the most likely surgical complication would be a bile leak. Surgical site infection, it's very common post-surgery, but it wouldn't present with, not necessarily with bilious content in the drain. I know the temperature is raised, but this can happen with a bile leak. Now, next, so we'll just go through some general complications that's post-op. So surgical site infection, very common. You treat it, it can range from like cellulitis to a surgical wound abscess, and you treat that with antibiotics. Surgical wound dehiscence, so that's when you've sutured or stapled the surgical wound site, and then it starts coming apart, and you can have a partial thickness or a full thickness wound dehiscence. So partial thickness is more easily fixed. Full thickness is disastrous because especially in general surgery, what can happen is in full thickness is you get bowel protruding outside the wound, and it's quite bad. The factors that influence that is things that affect wound healing. For example, a low albumin in the blood. Albumin is a very important marker of wound healing, and if it's low, it can cause wound dehiscence. Previous wound dehiscence as well increases the risk of further wound dehiscence. Sepsis, common after surgery, can be due to things like anastomotic leaks, again, can be due to surgical site infection, if it spreads in the circulatory system. Post-operative pain, again, very common, things that you get asked to see patients for on your on-call shifts. Just making sure that their analgesia is optimized. Usually if someone's had major operation, they'll be on a patient-controlled analgesia, so PCA, and then they'll be gradually stepped down to opiates, and then gradually step down to just kind of paracetamol. Post-operative nausea and vomiting, also very common, sometimes due to the GA agents that are used in theatre. So just making sure that these patients are prescribed good antiemetics. Post-op hemorrhage can occur as well. VTE, so blood clots. The patient might be less mobile, and all of that surgery in itself is a very is a very common risk factor for blood clots and delirium in elderly patients. Now, complications during a cholecystectomy itself, so it can be due to bile duct injury, as we've talked about, and bile leak. If it's very difficult to do the cholecystectomy, then they might need to convert it to open surgery. Patients might present with diarrhea, steatorrhea, or reflex gastritis after the surgery when they, for example, they have their clinic follow-up, and that's likely because they don't have a gallbladder to store bile anymore. So when they eat, they might not have enough bile that's going into the bowel to help break down fat and to help with fat absorption. Okay, next question, if we can have the poll, please, Holly. Great. Okay, so we'll end it now. It's a split answer between A and C. So this is one of those questions where I say read the question carefully and see what is asked. So this patient presented with right upper quadrant pain and jaundice, and they've got their tachycardic, slightly low blood pressure, temperature is high, so they have a fever. What do you guys think is going on with this patient? What do they have? Yes, they do have PSC, yes, and acute ascending cholangitis arising from it. So here, the most likely diagnosis is ascending cholangitis. Which of the following would be the most appropriate initial management? So the word initial is key here. So, and the answer is IV antibiotics. If this said definitive, then we could consider ERCP surgery. But the question is very clear here. It's asking about the initial management, and it would be, out of all these options, it would be IV antibiotics. Okay, so ascending cholangitis, as I said earlier, it's due to obstruction of the CBD, can be due to stone and stricture, cancer, and this leads to stasis and bacterial proliferation and infection. Most common organism is again E. coli. So do you guys know like the presentation triad for ascending cholangitis? What symptoms make up Charcot's triad? Yes, very good. It's fever, right upper quadrant pain, and jaundice. Exactly. Keep getting emails, sorry. Okay. Yeah, that's correct. And then there's something else that can be used as well to define the symptoms that accompany ascending cholangitis, and that's Raynaud's pentad. So yes, exactly. So you have your Charcot's triad plus shock and confusion. So investigations would be your full blood count, your LFTs, which will show an obstructive picture. So this means your ALP would be raised more compared to your ALT and AST. enzymes. Your urea and electrolytes, because they're acutely unwell, coagulation screen. You can also do a group and save as well. I forgot to add that, but you do that in case they need a procedure during their admission. So the first line imaging is an abdominal ultrasound scan. The gold standard is an MRCP. So first line you do the abdominal ultrasound. If you see dilated CBD, it could be that a stone has passed or there might be a stone there, then you do an MRCP. If this MRCP is positive for CBD stones, then they go for an ERCP to decompress the biliary tree. Yeah, so management, as I said, IV antibiotics, IV fluids, those would be your initial management, and then your definitive management, depending on the cause, would be ERCP or surgery. So ERCP, the way they do it is it's an endoscope, so it goes through the gullet, it goes through the stomach, through the duodenum, and it goes through here, through your ampulla vata, and up the CBD, where, if there's a stone, they'll break the stone and remove it. If there's a stricture, maybe they'll insert a stent or something to help make it more patent. So yeah, that's how ERCP works. Next question, if we can have a poll, please. Okay, we'll end it here. So most of you guys got the correct answer, so which is A, a calcium level of 1.9. So here we have a patient who comes in with sudden onset severe abdominal pain, radiating to the back. They are sweaty, pale, blood pressure is low. They've got a significantly raised MLA's level. So what is the most likely diagnosis here? Could you guys put it in the chat? Yes, it is. It's acute pancreatitis. So the question is asking you which of the following would be a marker of poor prognosis, and we've got these criteria. So the modified Glasgow score, and the mnemonic is pancreas to remember the different components. And this is a question that this is a kind of question that I've seen in exams before, so it's worth remembering this score. So these indicate the markers of poor prognosis in acute pancreatitis. So partial pressure of less than 8, age above 55, white blood cells more than 15, hypocalcemia, a urea which is greater than 16, enzymes which are high, and albumin which is less than 32, and a high blood glucose as well. So here in this, the only other answer that people picked was C, so urea higher range of normal. That would be incorrect. A urea of more than 16 is quite raised, so that's why it's wrong. And yeah, CRP does not form part of the modified Glasgow score, and gallstones doesn't form part of that as well. Next, so I think everyone knows the causes of acute pancreatitis now. We've all learned this mnemonic, get smashed, so I've just included it here, but just to bear in mind that the most common causes would actually be alcohol and gallstones, and the other causes are quite rare. ERCP is another one that can be common, especially in hospital when you're working on general surgery, you might see that. Presentation is the epigastric pain, typical radiating to the back, relieved by sitting forward, worse when you're lying flat. Signs of hemorrhagic pancreatitis, so colon sign and Grey Turner sign. I meant to add some photos of this to the slides, but I could not find good ones to show the signs. So colon sign is periumbilical bruising, and Grey Turner sign, you see bruises around the flank areas. Third space fluid sequestration, which happens because there's inflammation, and this leads to increased permeability of the blood vessels. This in turn leads to hypervolemia and AKI. This is why in acute pancreatitis you need to give a lot of IV fluids. So the amylase level in acute pancreatitis, if it's 3 times the upper limit of normal or more, this is highly suggestive of acute pancreatitis. If it's less than that, then we can consider other differentials. So the first 2 management strategies here, so the IV fluid resuscitation and the strict fluid balance monitoring, is for obvious reasons. It's because of the third space fluid losses. Analgesia, because it's very painful. It can give antiemetics if they're feeling nauseous as well. Antibiotics are not advocated in acute pancreatitis, so that's something to bear in mind. Next question. If we can have a poll, great. All right, we'll end it here. We've got a bit of a spread here as well, so we'll go through this. We've got a 57-year-old man, epigastric and right upper quadrant abdominal pain, background of chronic pancreatitis and alcohol excess. So on examination, they appear to be jaundiced, and they're tender on palpation. Their physical observations are normal. Blood tests show markedly raised ALP. That's all that's mentioned here. He has a CT scan, and it shows a well-defined walled-off collection of peripancreatic fluid. Which of the following is the most likely diagnosis? So most likely is the important kind of keyword here as well. So the answer is C, pancreatic pseudocyst. So the most common local complication of chronic pancreatitis is something called a pancreatic pseudocyst. So it's a collection of fluid around your pancreas or around part of your pancreas. Now, the reason why this patient is jaundiced is because this collection of fluid is kind of obstructing the biliary tree. It's pressing against the CVD, and it's causing obstruction. So that's why they're jaundiced and they've got a raised ALP. Bearing in mind that physical obs are normal, so it's less likely for them to be having to actually have an abscess. An abscess would present with like swinging fevers, abnormal temperatures. His blood tests, we've gone through that. So the raised ALP is because it's compressing the CBD. It has a CT scan, and that's the collection. So the reason why it's pancreatic pseudocyst is because it's the most common local complication of chronic pancreatitis, and there's nothing in the question that would point you to one of the other answers. So gallstone disease unlikely. There's nothing in there that would make you think that. Maybe the raised ALP and the jaundice, but obviously there are other causes for that, so that's something to bear in mind. Pancreatic cancer, it is a complication of chronic pancreatitis, but you would see something more in the lines of painless mass on palpation, so like painless cholestasis, painless jaundice. Pancreatic pseudocyst we went through, pancreatic abscess we went through, cholangiocarcinoma, again, you would feel the painless mass on palpation of the abdomen. And also there's no risk factors on there for cholangiocarcinoma. Yeah. So local complications of pancreatitis, and this is just a summary or a table, just to go through some of the local complications that can occur after either acute pancreatitis or chronic. So if we go through all of them, so acute peripancreatic collections, they usually occur early, so less than 4 weeks after an acute pancreatitis episode. Usually asymptomatic if they're small. You can have abdominal pain if they're big. And the way you would diagnose is through a CT abdomen pelvis. So in pancreatitis itself, it's a clinical diagnosis, but if you're suspecting local complications, then you would order a CT abdomen pelvis to look into that further. So this is usually the acute one is usually fluid collection due to inflammation or rupture of small ducts, and you would normally expect a spontaneous resolution for that. A pancreatic pseudocyst is the commonest local complication of chronic pancreatitis. That's why it's the answer. So it usually occurs late, or more than 4 weeks if it's after acute pancreatitis. So it can occur in both of them. It's asymptomatic if it's small, and you get symptoms if it's big. It's normally a walled off collection of peripancreatic fluid and necrotic material. So for all of these, you diagnose them with the CT abdomen pelvis. They may need drainage if they're big enough. Pancreatic abscess, more than 4 weeks, usually after acute pancreatitis. They present with fever, abdominal pain, nausea, and vomiting. So they are quite unwell with it. So normally it can be due to infection of a pseudocyst, and management would be with IV antibiotics and drainage of the pus. Necrotizing pancreatitis, so this usually occurs within 24 to 48 hours of acute pancreatitis onset. So it presents with abdominal pain, vomiting, fever, and you can see that the symptoms, they're not improving at all despite you starting, the management, the resuscitation fluids, and the analgesia and all of that. So what happens in necrotizing pancreatitis is part of the pancreatic tissue dies. If this is chronic, it can become walled off. The way that you treat this is through percutaneous drainage if there is a collection. If otherwise, they would need a necrosectomy, so they would need surgery to remove this necrosed part of the pancreas. So next question, if we can have the poll, please. Great. Okay, we'll end it here. So most of you got the correct answer, which is the early onset dumping syndrome. So here we've got a 65-year-old lady, and they are going to their clinic appointment, and they've had a total gastrectomy for gastric cancer a few weeks ago. Oh God, I made a mistake here. Apologies. This should say she. So they have been feeling unwell, faint and clammy about 10 minutes, following all of their meals. This is usually associated with palpitations, following which they experience syncope. So which of the following is the most likely cause of the symptoms? So it is early onset dumping syndrome, and let's go through this. So what happens in a total gastrectomy? So total gastrectomy means resection of the whole stomach. Okay, so that's what's happened here in this diagram. So if you visualize a normal GI tract, so ignore this, the stomach would have been here, and this would be the duodenum joining to form with the jejunum down below. So what happens is they remove the stomach, and then they form a Roux-en-Y reconstruction. Sounds fancy, but it's quite simple and quite interesting. So they cut the small bowel in a portion of the jejunum. They bring the jejunum up to connect to the esophagus, to the end of the esophagus, and then here they close the stump of the duodenum, and then they reconnect the duodenum here to the jejunum. So what's happening here? So if someone's eating, this is going straight to this section of the jejunum, yeah? And then here you've got this duodenum, which wasn't removed. This duodenum is still receiving enzymes from the pancreas here, okay, in the second part. And then these enzymes go to the jejunum to help digest the food here. So it all comes together. It's very interesting. You can read about it in your own time. We won't go through it more than this, but what it means is that when someone's eating, the food is going very quickly to the small bowel. Okay, and what can happen is because of this hypertonic contents entering the small bowel rapidly, you can get a fluid shift into the small bowel, and this leads to hypervolemia, and this activates the sympathetic nervous system, and they get tachycardia, nausea, they feel faint. And it normally occurs about 10 to 30 minutes after food intake. Now, late dumping syndrome usually occurs 1 to 3 hours after eating, and the food is absorbed from the bowel, and this leads to a sudden rise in serum insulin levels, and this in turn causes hypoglycemia, and this also leads to a sympathetic response. So yeah, that's why the answer was early dumping syndrome and not late dumping syndrome, and also not hypoglycemia, because that's the mechanism behind late dumping syndrome. Okay, next question, if we can have the poll, please. Okay, we'll end it here. Most of you got the correct answer, which is D. Hold the combined oral contraceptive pill for 4 weeks before proceeding. So we have a lady who's awaiting an elective cholecystectomy, and they don't have any past medical history. They only use the contraceptive pill. So he is asking which is the most appropriate action to take with regards to the combined oral contraceptive pill, and the answer is D. So the contraceptive pill is usually stopped 4 weeks before an operation, and it's restarted 2 weeks after the operation. And this is because of the risk of blood clots when you're on a combined contraceptive pill. So it wouldn't be safe to proceed with the surgery while they are on the pill, and you wouldn't want to cancel their surgery indefinitely just because they are on the pill. This is wrong, so it's the wrong time frame. Switch oral contraceptive to alternative contraception and proceed with surgery next week is just a bit of a hassle to do that. So switching to another contraception is not as simple. It's not as simple. And it can take time anyway to become established on another type of contraception, and then you would need to change that back after the surgery. So it could be done, but the most appropriate action would be D. So bearing in mind that this was an elective operation, so you could afford to delay it as well while you're holding the pill. So these are just some common medications which need to be stopped pre-op. I forgot to include your DOAC on there, but your DOAC would usually be stopped around 2 days before surgery. So anticoagulants or antiplatelets. So your antiplatelets, clopidogrel, is usually stopped around 7 days before surgery, and that's because your platelets take around 7 days to form anyway. Warfarin, you need to stop that 5 days before surgery. Apixaban about 2 days. When you stop an anticoagulant, you need to switch them to low molecular weight heparin treatment dose, just to prevent them from having adverse events. Low molecular weight heparins, they can be given until the night before surgery, so that's quite useful. The combined pill, we've talked about that. Diabetes medication, so if someone's on insulin, like in a type 1 diabetic or a type 2 diabetic patient who's also on insulin, in ill-by-mouth patients, they are not eating, so you need to start them on something called a VRII, so a variable rate insulin infusion, and that goes through the vein. At the same time, you continue their long-acting insulin, but you need to suspend the short-acting insulin that they have with their meals or with their snacks. Sulfonylureas, you stop them on the day of surgery because they're also associated with a risk of hypoglycemia. ACE inhibitors, you stop them the day before surgery because they are linked with, they're a risk for hypotension when someone's having an operation under GA. Next question, if we can have the poll, please. So this one is a bit of a hard question. I appreciate that, but still most of you managed to get the correct answer, which is B. So it is a direct inguinal hernia. So to understand inguinal hernias, you need to know a bit of the anatomy. And I know a lot of people don't like anatomy, so bear with me while I go through it very quickly. So here we have a patient who is admitted for an elective abdominal hernia repair. The lump is felt above and medial to the pubic tubercle, so it's above. During the operation, it is noted that the hernia lies medial to the inferior epigastric vessels, which are the following does the patient have. So let's go through the answers. So a femoral hernia would be below the pubic tubercle based on a location. That's why it would be incorrect. An indirect inguinal hernia. We'll go through all of them and what they mean in a second. Indirect inguinal hernia would be lateral to the inferior epigastric vessels. A Spigelian hernia is something that most of you probably haven't heard about before. It's essentially a hernia that occurs through the linea semilunaris, where you have a weakness in the abdominal wall. So it's at the lateral border of the rectus abdominis muscle. And then you know what an umbilical hernia is, but that's this wouldn't be an umbilical hernia. So let's look at some anatomy quickly. So this is the Hesselbach's triangle, or the inguinal triangle. These are the inferior epigastric vessels. This is your inguinal ligament, and this is your rectus abdominis muscle, and this is the triangle here. So if you have a hernia during the operation and you see that it's medial to these vessels, it's a direct hernia, it's protruding through the wall, the posterior wall of the inguinal canal. And if you've got something that's lateral, that means the hernia is going through the deep inguinal ring, and this is lateral to the inferior epigastric vessels, and this would be an indirect inguinal hernia. So this is just looking at a sagittal cross-section of the inguinal canal, just to look at what these are made of. So the anterior wall is made of the aponeurosis of the external oblique. The roof is made of the internal oblique and the transversus abdominis, and also your transversalis fascia there. That's also your posterior wall here, and this is your inguinal ligament, which forms the floor. So a direct hernia is when you have the bowel or the content protruding through a defect in the posterior wall within the inguinal canal, and then it goes out through there, through the superficial ring. But the indirect inguinal hernia would protrude through the deep inguinal ring, and then it goes through the canal and through the superficial ring. So if you imagine it, so in between around here, you would have your inferior epigastric vessels there. So medial to it, you would have something, you would have a direct hernia, and lateral to it, you have your deep ring, so you have your indirect hernia. So this is just a summary table, direct versus indirect. So direct hernias, we've talked about it because of a weakness in the wall itself, and this is due to raised intra-abdominal pressure. Example, heavy lifting, constipation, smoking is also a risk factor. Indirect hernias present in younger patients, usually congenital, where you've got a patent processus vaginalis, which means that the content of not the content, but the small bowel can actually protrude through that and go into the scrotum. It's rarely descends in the scrotum in males for the direct, but for the indirect it happens often. If you put pressure over the deep ring, as we explained on the previous slide, this wouldn't reduce a direct hernia, but it would reduce an indirect hernia. And then, just as a fact, indirect hernias are more likely to strangulate compared to direct hernias. And the management is open or laparoscopic mesh repairs, and the way you decide between both is essentially, if someone has bilateral inguinal hernias, or they have recurrent inguinal hernias, then you opt for laparoscopy. Otherwise, you go for open. Next. So next question, if we can have the poll. Brilliant. Okay, we'll end it here. So this is one of the genetic syndromes. So it's a question about that. I didn't really cover cancers in this lecture because there was a previous lecture about all the oncology and stuff. But I wanted to cover some of the genetic syndromes. So you have a lady who presents to clinic and they've been experiencing PR bleeding and unexplained weight loss. They don't have any past medical history, but they do have a significant family history of cancer on the maternal side of the family. So maternal aunt had bowel cancer in her 40s, maternal grandfather suffered from renal pelvis carcinoma, mother had endometrial cancer. She's concerned that there is cancer running in her family. Which syndrome is she most likely to have? And the correct answer is D, which most of you got right. And we'll go through a summary of each of these conditions in a little bit. I just want to explain a little bit why the other answers are wrong. Sorry. So A, von Hippel-Lindau syndrome is not usually associated with colorectal cancer. So you would usually exclude this answer when you look at the options. Peutz-Jeghers syndrome, for that one, that's associated with hematomatous polyps in the colon and also hyperpigmentation of the mucosa. Now, it's not common for these polyps to undergo malignant transformation, because of the sheer number of polyps that these people have, their risk of having cancer is higher anyway than the average population. In this question stem, you have a patient, the family member, bowel cancer, renal carcinoma, endometrial cancer. All of these associations, they point towards HNPCC as opposed to the others. So FAP, this one is linked usually with duodenal cancer as opposed to endometrial cancer. Gardner syndrome is a variant of FAP, and we'll look at this on the next slide. So this is just a summary, and just for exam purposes, for you to remember some key kind of terms, and when you get question stamps, it's quite easy to match them to that. So Lynch syndrome, when you have a mutation in MLH1, MSH2 genes, and these are mismatch repair genes, so it is an autosomal dominant inheritance pattern disease. There is a risk of colorectal cancer in people who are in their 30s, and it's associated with gastric, endometrial, and renal cancers. FAP is a mutation in the APC gene, autosomal dominant as well. You have the patients will have loads of polyps in adolescence, and this increases the likelihood of colorectal cancer when they are in their 20s. That's it. It's kind of assumed that they are going to have cancer at some point because of the sheer number of polyps that they have. So in order to prevent that from happening, what will normally happen is they will have a prophylactic resection of the colon and the rectum as well. This condition is associated with duodenal cancer. So they will have surveillance with endoscopy regularly. Gardner's syndrome is a variant of FAP and it's associated with dental abnormalities, osteomas, thyroid tumors, and that's not mentioned in the questions then. And as I said, for this condition, you've got a mutation in the STK11 gene, autosomal dominant as well, and these are pretty much what it's associated with. And for this one, there is a generally increased risk of colorectal cancer in this population compared to the general population. So they have regular colonoscopy for surveillance compared to FAP, where they would just have surgery. Next one. Nearly there. Great. So this diverticulitis was something that I covered in one of my previous lectures, but I just wanted to include it for completion in this one. So we'll not spend too long on it. But yeah. Okay, we'll end it here. So most of you guys got the correct answer, which is D, an emergency Hartmann's procedure. So let's see why that's the case. So we have a patient, they've got diverticular disease, they are in severe abdominal pain. When you examine them, they have signs of peritonism with widespread rigidity and rebound tenderness. So their observations, they are not hemodynamically stable either. Their respiratory is a bit high, the temperature, they've got a fever. They have an erect chest X-ray which shows pneumoperitoneum. So this makes you think of a potential perforation, which is very bad. And so here we're asking about the definitive management. So in cases of diverticulitis, which is this bad, we normally opt for surgery, and this is a Hartmann's procedure. It wouldn't be the other surgical option, and I'll explain why in a minute. So if someone has peritonitis, usually we take them to theatre as an emergency and we do an emergency laparotomy. So that's a long midline incision, okay? And we look for the cause of it. Now, in this patient, we think that they've got a perforation, and it's likely because of acute diverticulitis. Now, IV antibiotics would be inappropriate. It wouldn't be the definitive management. It would be the initial management, but not definitive. Emergency laparoscopic repair, this would not be correct because, as I explained, they will need a laparotomy. Oral antibiotics for obvious reasons inappropriate. Emergency bowel resection and anastomosis. So where is this occurring? This is occurring in the sigmoid colon. If you resect that bit of the bowel and then you anastomose, it's very unlikely to heal well, especially in someone who is this unwell as well. You don't want to do that. You don't want to resect and then anastomose. A Hartmann's procedure, we'll come to what it is in a minute. Essentially, I'll just explain it, but I've got a diagram explaining it coming up shortly. So what it is you resect the sigmoid colon, the sigmoid colon, so that bit which is affected, which is perforated, and then you bring the distal end of the descending colon up, so as an end colostomy, and you close the rectal stump, the rectal stump. So that means that you wouldn't be relying on an anastomosis to heal. Okay, we'll just quickly go through this. So diverticulosis is just diverticular present, diverticular disease. They have symptoms, but there's no infection or inflammation. And diverticulitis is inflamed, infected diverticular. And these are risk factors for it. So if they've got low fiber diet, they're smokers, they've got a sedentary lifestyle or obesity, clinical features, left lower quadrant pain, changes in bowel habits, PR bleeding, pyrexia, deranged physical obs, when it's in the worst stages of diverticulitis. Now, do you guys know which classification system is used for acute diverticulitis? Lovely. Yeah, indeed. It is the Hinchey classification. So the Hinchey classification is very important because it determines your management. So 1 and 2 are not as severe, and they're not as severe diverticulitis, so you can manage them with oral IV antibiotics. But 3 and 4, stage 3 is purulent peritonitis, so where you've got spread of the infection across the abdomen. And 4 is feculent peritonitis, where you've got a perforation in the bowel at the site of the disease, and this is resulting in leakage of like fecal material in the abdomen. And these 2 are very bad, and these 2 need surgery. So this is just a summary of investigations that you need to do for someone with diverticulitis. So just the infection markers, looking at the user-Nees, and then your clotting and your Gribben before they have surgery. Lactate will tell you about ischemia of the bowel, blood cultures if they're septic, CT abdo-pelvis is the gold standard. And then, as we saw in the question, if you think there's a perforation, you do an erect chest X-ray, obstruction abdo X-ray. And if there is significant PR bleed, you do a CT angiogram to look at the vessels supplying the bowel. Management, we've talked about this before, but essentially just making sure that they eat well, they've got laxatives prescribed, and they use analgesia as required. And this is just a diagram of what I talked about with the Hartman. So you've removed this section, and then you bring this section up, form an and colostomy, and then you close this stump here. At a later point, when they are well, you can do a procedure that reverses this, and it is called a reversal of Hartman's. Okay, next question. Okay, I'll stop it here. So there is a split between B and D. The answer is B. So it's asking for the gold standard investigation. So here we have a man who's got severe central abdominal pain, sudden onset. Sudden onset is key. Feeling nauseous, not vomiting. Analgesia have not been helpful. Examination, they are tender, but there is no signs of peritonism. And they've got a background of type 2 diabetes, AF, and obesity. The VBG findings show a raised lactate as well. So here, the most likely diagnosis is something called mesenteric ischemia. So what points to this condition is the fact that it's sudden onset, and they've got a background of AF. So it could have been an embolus that's gone into a blood vessel that supplies the bowel, the small bowel. Also, something to bear in mind is the fact that they're in so much pain, but um, clinically, the signs elicited, they're not in keeping with this level of pain that they're experiencing. So this also makes you think, oh, could this be mesenteric ischemia? Anyone who's got AF and they present like this, you need to think about this differential diagnosis, the mesenteric ischemia. The fact that they've got a VBG which shows an acidosis and a raised lactate as well, that also points to a mesenteric ischemia. So that's why this is the most likely diagnosis. Now, once you've found this out, then what is the gold standard investigation for this? And that's a CT angiogram. And the reason is it helps you look at the blood vessels and see if there's something obstructing it, obstructing the blood supply. So this is just a table. So there's something called mesenteric ischemia and ischemic colitis. So mesenteric ischemia usually affects the blood supply to small bowel. Ischemic colitis normally affects the large bowel blood supply, and it's normally most the watershed areas, which means it's where you've got two main blood vessels. It's this section in between those two main blood vessels. And I'll explain it. I've got a diagram in a bit. Clinical features, mesenteric ischemia can present with acutely and with severe sudden onset abdominal pain that's disproportionate to clinical findings, as we saw in the question. Chronic presentation would be postprandial kind of colicky pain. And if you think about it, it's more like you could compare it to angina, for example, where someone with risk factors like hypercholesterolemia, type 2 diabetes, hypertension, they can have a blood clot or like thrombus formation, and this presents as a chronic symptoms. So investigations, gold standard is CT angiogram for mesenteric ischemia. Gold standard for ischemic colitis is colonoscopy, and management for mesenteric ischemia is endovascular embolectomy or thrombectomy. For ischemic colitis, it's less acute. It would normally present with, it can be very severe pain, but it would normally present with bloody diarrhea as well compared to mesenteric ischemia. And you normally start with conservative management first, and you only go to surgery if this management fails, or they're peritonitic, or they've got a perforation. So the presentation differs between the two of them. So this is just anatomy. So this is the superior mesenteric artery, and this is the most likely to be affected in mesenteric ischemia. So if this is blocked, then as you can imagine, you would have reduced blood supply to the small bowel, which will become ischemic. Ischemic colitis, on the other hand, usually affects these two watershed areas. So this is the area between the blood supply of the superior mesenteric, which supplies this bit, and the inferior mesenteric, which supplies there. So this area in between the splenic flexure receives a bit less blood. And then here you've got around the sigmoid colon, where you have your where you've got inferior mesenteric supplying, but then afterwards you have superior rectal taking over. So this area in between is a watershed area. Okay. Next. Okay, I'll stop it here. This was a bit of a harder question, but if you read through it and you understand it, which we will aim to do, it will be fine. So here we've got a patient presenting with colic, abdominal pain, vomiting. They haven't opened their bowels. They've got a previous history of hysterectomy, abdomen's distended, tinkling bowel sounds, and this is the abdominal X-ray. What do you guys think is going on that X-ray? Very good. This is small bowel obstruction. So given the most likely diagnosis, which of the following is an indication for surgery? So usually the way you manage small bowel obstruction is you start with conservative management, which is IV fluids and which is drip and suck. So giving IV fluids and putting a RIAS tube in to decompress. So that's how you would start the management of small bowel obstruction. Now, there are a few exceptions when you would want to do surgery as soon as possible. Now, a small bowel diameter, 4 centimeters on an abdominal X-ray, this indicates small bowel obstruction, but this on its own, it is not an indication for surgery. Raised lactate, the lactate would be raised anyway in small bowel obstruction. And the reason for that is because people with small bowel obstruction have a lot of fluid losses into their bowels. So they become dehydrated, and when that happens, the lactate rises anyway. History of Crohn's disease. Sure, Crohn's disease might mean that they've had previous surgeries and it might indicate adhesions, but again, that's a cause of small bowel obstruction, and it does not tell you they need surgery. History of previous surgeries, again, same thing. The correct answer is D. So a strangulated hernia is the right answer. I'm sorry, I don't know why it's not highlighted, but this is the correct answer, and the reason is when a hernia is strangulated, it means that the blood supply is cut to that section of the bowel. So that means that section of bowel is going to become ischemic and will die if they are not operated on as an emergency. Okay, so small bowel obstruction, quickly, usually mechanical, most common causes adhesions. It can be functional as well, but rarely. Crohn's disease and incarcerated hernias as well can be causes of small bowel obstruction. Clinical features, which was everything that was described in that question. Investigations, you have your bloods, you do a VBG to have an idea of what's going on with the patient, because you have that's something that you can immediately get compared to the other blood tests. And then you need to send off the clotting and the group and save that as well, bearing in mind that they might need surgery. Imaging, so abdominal X-ray, and then once you've done the abdominal X-ray, you see the distension, then you need a CT abdo-pelvis to confirm the underlying cause. And so management, drip and sex, a RIAS tube to decompress, IV fluids for resuscitation and to replace third space losses, all of that, analgesia and diemetics. If these fail, or as we found out, if there's strangulated hernia as a cause and something that's not adhesions, then they would need surgery. So large bowel obstruction, this is an abdominal X-ray that shows large bowel obstruction. The way you compare it to the other one that we just saw, so you can see that these lines across, they are the claustra, and like they are incomplete. They're only halfway across, whereas there, the valvulae conniventes, they were completely across the section of bowel. Yeah, and these also appear more distended compared to the ones in the small bowel X-ray. What do you guys think this shows? Yeah, it is a volvulus. It is a sigmoid volvulus. And that's, you can see it's the coffee bean sign, very typical. And this is a sigmoid volvulus. So management is similar to small bowel obstruction with the IV fluids, the royals to decompress if they're vomiting. Vomiting is usually a later sign in large bowel obstruction. If you think about where the obstruction is, if they were to vomit, they would it would occur later, and they could be vomiting feculent matter as well. So you address the underlying cause. So can be malignancy. So if it's colon cancer, you can resect or stent while they're in even though they're in obstruction. But rectal cancer, you do not want to be resecting the cancer while they are this unwell. And also rectal cancer is one of those which easy to spread and quite complex surgery is needed to treat them, and you need to actually you need lots of imaging and planning for the surgery. So it would be inappropriate to actually resect the cancer then while they're in obstruction. Instead, you do a defunctioning colostomy where you bring large bowel up to the abdominal wall and you attach a stoma bag. Sigmoid volvulus is a sigmoidoscopy and flatus tube insertion, and then to decompress, and then cecal volvulus is a right hemicolectomy. There's things that can come up in questions. We only have 3 questions left, and we will go through them quite quickly. Okay. So most of you, if not all of you actually, you got this question correct. And the answer here is C. So you have a 14-year-old who's brought to ED, severe right iliac fossa pain, palpation. You can see this is Rovsing sign, so where you palpate the left iliac fossa and they feel pain on the right side. The pyrexial, you can see that the CRP and white cell count very, very raised. The most likely diagnosis here is in keeping with appendicitis. And here in this patient, because you have such a strong, diagnostic suspicion, this is surely appendicitis, you're going to go for a diagnostic laparoscopy plus or minus appendicectomy as your next management for this patient. This patient, bearing in mind they're 14 years old, so radiation would be inappropriate. MRI abdomens take very, very long to do. It's inappropriate in this case. Emergence laparotomy is not indicated in appendicitis, unless obviously they are completely peritonitic and they've had a perforation or something. Abdominal X-ray is not indicated. Only maybe in a case where you might use some imaging on a young person who you suspect appendicitis on is if the infection markers are not very convincing for it, or they have very mild fever and the pain is not as severe, then you might do an ultrasound scan of the abdomen in the young patient. But in this case, the answer is definitely C. This diagram just shows like various positions in which you can find the appendix, and the most common position is retrocecal. So this appendicitis is usually caused by a fecalith obstructing the lumen of the appendix, and we talked about this, and so this was described in the question stem. So they present with periumbilical pain which migrates to the right iliac fossa, anorexia. So it's more common in appendicitis is the nausea as opposed to vomiting, and then fever as well. Rovsing sign with I've explained that. And psoas sign is when you get them to flex their hip, and then they get pain on the right side. So these are just investigations, your typical surgical bloods, and then imaging. If uncertain diagnosis, you can do CT abdo pelvis in adults, especially in older adults. If they're presenting with symptoms of like appendicitis, you do want to do the imaging first to make sure that there's nothing like a mass or like maybe a cancer or a tumor at that site. So it's worth doing an imaging in older adults. In children, if there's uncertainty. And then you mostly do laparoscopic. Open is rare for appendectomies. And then complications, if they've got an abscess or an appendix mass, then you would give them an IV antibiotics, and then you would do an interval appendectomy as opposed to doing it right then and there. So next question. Okay. All right, we'll end it here. Most of you got it right, and the answer is E, it's hemorrhoids. So this is a young lady, and she's got a history of constipation. She has, so constipation is a risk factor for hemorrhoids. She has PR bleeding over the last few months. It's bright red and it's painless. It helps you differentiate between something like an anal fissure from a hemorrhoid. Anal fissures are very painful. Perianal abscesses are also very painful. So the fact that this is painless makes this less likely. She also experiences itchiness. Itchiness is a symptom that's associated with hemorrhoids. She has noticed a lump. It disappears after defecation. PR exam is unremarkable. She has no relevant post-medical family or social history. Most likely diagnosis. So it's not going to be anal carcinoma. She doesn't have risk factors for that, and she's very young. Rectal prolapse is also very, very unlikely in such a young patient. So moving on to hemorrhoids, usually it occurs because of an expansion and protrusion of the anal vascular cushions outside the anal canal. Risk factors include raised intra-abdominal pressure, example constipation, space-occupying lesions. In this case, the patient had constipation. Portal hypertension also can cause hemorrhoids. Clinical features, you get bright, PR bleed on defecation, a protruding mass, and pruritus ani, so that's anal pruritus. Management, so you encourage a fiber and fluid-rich diet. Constipation, so for example, put them on laxatives, topical steroids for pruritus. Rubber band ligation is the most common management if it's a hemorrhoid that prolapses and needs to be it prolapses, and then it goes back in spontaneously, or it has to be manually reduced. Sclerotherapy is injection into the hemorrhoids, and it helps shrink it. Hemorrhoidectomy is the surgical management where you resect the hemorrhoid, and that's usually for worse kind of hemorrhoids where they prolapse outside and you can't bring them back into the anal canal. Thrombosed hemorrhoids, this is very, very painful. Usually you treat it with ice packs, lidocaine gel, laxatives, and surgery if the symptoms don't resolve with the above. Final question. Okay, we'll end it here. So very interesting. Most of you have gone for C, but the answer is actually D, is incision and drainage under general anesthesia. And we'll go through why that is. So you have a 25-year-old man, background of Crohn's disease, perianal disease related to Crohn's disease. They have pain in the perianal region, struggling to sit down, struggling to walk, feeling feverish, and fluctuating perianal mass, and which is very tender and warm to touch. So you're thinking about a perianal abscess. Now, the definitive management for a perianal abscess is usually incision and drainage under general anesthesia. And the reason for this is because it's very, very, very painful, and it cannot be done under local. Even the guidelines or textbooks, when you read on websites, it would teach me surgery and everything, usually perianal abscesses, they need to be drained under general anesthesia. So anorectal abscesses in general, so sorry about the noise, infection, it's usually due to infection, collection of pus in the anal rectal region, and it's caused by plugging of the anal ducts that release mucus into the anal canal to help with defecation. So clinical features, we've described them all in the question, in the question stem, and it's classified according to location. But in the question, we are talking about a perianal abscess. This is the most common type of anorectal abscess. So investigations that you go for, usually blood, so your usual surgical bloods, including the clotting and group and save, because they're going to undergo a procedure. If they have an atypical presentation, like for example, perianal Crohn's disease or complex fistulas, normally we do an MRI pelvis before operation. But in the question, we asked about definitive management. We didn't ask about this. But just bear in mind that atypical presentations, we need to do an MRI pelvis to look at the anatomy. Management, so antibiotics, analgesia, and incision and drainage under general anesthesia. And that's it for today's session. This was also the last session of our finals teaching series for this year. So thank you everyone for attending throughout the year. It's been lovely to teach you guys, and I hope you found it useful. So we're not doing a finals revision day this like in June or July, but we will be doing something like kind of like a recap day in September, where people who maybe are going back into their clinical years after intercalation, or they're going into final year, will be doing like a recap of like most specialties on that day, and we'll keep you guys updated on our social media pages. That will be in September. You guys are very welcome. If you could please fill out the feedback form. Thank you. And thanks for coming. I will end it now or soon, unless there's a question that comes through in the next minute or two. Okay. Great. I'm going to end the session now. Good night, guys.